survival, that these mice, these MMA mice, all really die by about 3 weeks of age. Whereas if you treat them, they all survive. So this really looks like a very promising solution. They have another RNA that they've made for propionic acidemia, and let's see, we have 3 RNAs here, a control RNA that has nothing related to PPC in it, and then either a PCA plus, these are PCA plus PCCB, either at 0.5 milligram or double that dose. And what you can see is that when these mice are injected, the level of 2-methyl citrate, which is a marker of propionic acidemia, drops if you give them this drug. And they also have a decrease in their ammonia levels here with no coding sequence, and here with their combined propionic PPCA and B mRNAs, and the heart rate, as you know, cardiomyopathy is a problem in propionic acidemia, and in these animals that holds true. Also drops a little bit. We've been working with Moderna, along with some other metabolic centers across the country, to develop this for clinical trial. This has already received orphan drug designation and is recognized as being for a rare pediatric disease. And Moderna is getting ready now to start a study called the MAP study, which will allow us to start getting ready for a clinical trial. The first thing you have to do from the FDA standpoint in developing a clinical trial is to say what you're going to be treating. How are you going to tell whether or not it's working? So they need to know what the natural history is. And so one of the things we're doing is getting some additional information from from patients who have MMA, families who have children with MMA, on the course of the disease in their kids. I know that they've also been in contact with Dr. Venditti, whose group has lots of additional history, and the goal here is to see patients over the course of 3 years, collect data on them from on an every 6-month basis that will then form the cornerstone of the information that gets submitted to the FDA. This is going to be conducted along with your regular clinic visits. So if you're seeing your docs every 6 months, that'll get done. If it's not, then we actually probably have to throw in an extra one in there. I don't know, I see all mine at least every 6 months. So you're probably okay. And there's not going to be any additional procedures or anything that you're going to need to have done for this. There'll be a questionnaire, a quality of life instrument that we'll ask you to fill out. And so as I said, this is the first step to getting into the clinic. And a list of sites that are participating in this program. So if you're near one of these, if you'd like to participate, all you have to do is contact the site, and you can get yourself enrolled. Now the actual, I'll come back to that. The actual start of the clinical trial is still up in the air. Where they're talking to the FDA. They're working with the clinical sites to help develop the protocol, and so hopefully it will be sometime in the not too distant future. I told them that I would deflect all questions as to when back to them. So the Moderna folks are sitting in the back of the room there. You can raise your hands. Somebody over here, and I'd like to encourage you to go ahead and talk to them and try to understand a little bit about what this program is going to look like. Now, I'm going to give you a little bit of information that also was pertinent to the fatty acid oxidation disorder group. And excuse me, goodness, allergies. From the fatty acid oxidation standpoint, The reason that I bring this up is in the TCA cycle, patients with fatty acid oxidation disorders rely on this cycle for energy. And when we feed them MCT oil, this cycle runs and it runs and it runs and it runs and it runs until it runs out of, this is a 2-carbon unit, this is a 3-carbon unit that feeds into the critical succinyl-CoA molecule here. So this cycle needs 2 and 3 carbon units to run. Well, we get around that by giving them a C7 fat that generates 2 C2 carbons and a C3 carbon. Well, if not having enough C3 carbons is bad for those patients, what is it for patients who actually have a defect right here? It's significant. So patients with MMA and propionic acidemia have TCA cycle intermediate depletion, but we have no good way of getting that back. Some people are trying, you'll hear from Dr. Morton, is trying to give citrate. Some people try to give alpha-ketoglutarate, but it's hard to give enough of that to get to an effective level. So we've been working with a medical chemical group, medical chemistry group, to try to develop novel anaplerotic agents, things that will come in at some point in the TCA cycle and bypass this. I'm just going to go over that. So in fatty acid oxidation, we can just give them propionate or the C7 starting point, and it makes their cardiac status especially improves tremendously, and they have no problems then with energy metabolism because their hypoglycemia is gone. So we're looking for molecules that'll go into the cycle past propionate. One of the molecules we're working on is a succinate molecule. Triheptanoin, the drug that we're working on with fatty acid oxidation disorders, is 3 molecules of C7 hooked onto a backbone that looks like this, 3 carbons. This is called glycerol. So excuse me, turns out that this molecule itself isn't the right version. It turns out that trisuccinyl glycerol is glass. Don't ask me why. It's that are living through chemistry. It doesn't move. You can poke at it, and it's really kind of cool. But it also was kind of disappointing. So we went back to the chemistry books, and we now have other agents. We've got a succinate agent that's colorless, odorless, is a little bit sweet, very easy to take, and delivers high levels of succinate. We've got a citrate molecule that does the same thing. So we're working on these molecules in cells, and we're working on them in mice. And just to give you some idea of what this looks like, I have some preliminary data here. And one of the things that we can see in cells from patients with propionic acid and methylmalonic acidemia is that they have a signal looking at a bunch of biochemical markers that indicate that their mitochondria are under stress. These enzymes are in the mitochondria. Energy metabolism is broken in them to some extent. And if you look at the cell's ability to utilize oxygen to make ATP, the cellular energy, what you can see is that compared to normal, this is a propionic cell line. Which one is this? I think this is a propionic cell line. They can't use oxygen as well. So this is a decrease by a significant amount of money. If we turn around and instead now give them either citrate or succinate, the signal that you want to look at is here, here, and here. Let's see, succinate, no, citrate and citrate. This is citrate. So if we give them citrate, this signal, which is an attempt at the body from the cell to try to increase energy, so they're burning more oxygen, it's just not being effective, it drops. And that signal means that there's less stress on the mitochondria. Here with succinate, you see the same thing. If we give them succinate, the stress on the mitochondria drops. So this looks like it's doing something at the cellular level. We've tested this molecule on mice, and it also seems to improve their energy metabolism. So we're moving this forward into something, and to do some additional clinical trials, or animal trials, before we start moving into clinical trials. I would expect that it's probably more than a year, but it might be somewhere between a year and 2 years before we're ready to give these to patients. Now, talk to you a little bit more about mitochondria, because it's important I look primarily at energy metabolism, and I'm looking at either replacing the energy components that are missing, or in some way mitigating the secondary effects of the energy deficit. And when you look at mitochondria have this very, very complicated series of membranes inside the body, where all of the energy, all of the tips here, all of the energy enzymes are located. And if you give, if these come from a patient with, for example, a primary energy deficiency, this is all disrupted. And if we have a secondary energy deficiency, we don't have good pictures of this yet. But we have evidence that the function is abnormal. So we're looking at some compounds that will help stabilize this structure in mitochondria as part of what we're doing in treating fatty acid oxidation disorders. And we thought it was worth trying in cells from patients with propionic and methylmalonic acidemia. There's a special fat inside that membrane called cardiolipin that has a very unique structure that allows the membrane to take these right-hand turns that you need to make that membrane. And if that is disrupted, you end up with problems in maintaining normal energy balance. And one of the things that disrupts it is a process that in energy defects leads to an increase in what's called reactive oxygen species. When your cell makes energy, it's burning oxygen, making water, and harvesting the energy to make ATP. Well, that's kind of like the reaction that happens when you strike a match. You strike a match, you burn oxygen. In that case, you get carbon dioxide. But you get the energy from the oxygen, but you get it all at once in a flame. Well, we can't do that in the cell. You can't be the Human Torch. And so what the body does is it slows the process down enough through a series of chemical reactions that allows it to harvest that energy slowly over multiple steps and make that energy into ATP, the cellular energy. And those intermediate steps between oxygen and water are called reactive oxygen species. And they're protected from the cell by the proteins that do those reactions. But if those proteins are disrupted in any way, then that reactive oxygen slips out into the cell and can cause damage. I have to look and see. I can't remember what I put in here. So when we first started looking at these cells, we could see that there was an increase in reactive oxygen species in them, which, given what I told you about their energy metabolism being abnormal, probably not too surprising. But it gave us a reason to think about how we could potentially treat that reactive oxygen speed and see whether it would come down. Now, I've been involved in another clinical trial for disorders in that pathway that make the ATP, called the respiratory chain. And it's a compound called elamipretide, and it stabilizes cardiolipin in those patients. And what you can see here is in patients who have trouble walking, if you give them this this drug, it improves their muscle strength. So their energy is improving because of the stabilization of cardiolipin. So they said, well, what would happen if we gave this drug to cells and or mice with MMA or propionic acidemia? Well, I couldn't get the company to give it to me, so we made our own. That's shown here. So now here is you see a measure of increase in reactive oxygen species. So normal cells have 1. They're related to themselves. There's no increase. Propionic cells have almost 2-fold higher levels of reactive oxygen species. And when we treat them with one of these, the cardiolipin protein that I mentioned, it drops that by about 50%. So pretty good. We have, because there's a known way of getting rid of reactive oxygen species. That's an antioxidant. We said, well, what happens if we try antioxidants? We tried a whole variety of off-the-shelf and prescription antioxidants, and none of them would work. Instead, we have I have a very good collaborator at the University of Pittsburgh who's a chemical wizard, and he was able to make us antioxidants that got targeted to mitochondria, about 100-fold increase efficiency. And when we treat our fatty acid oxidation cells with that, for example, completely normalizes the reactive oxygen species. Here, what you can see, now again, in this case, in this experiment, the propionic cells had about a 3-fold elevation in reactive oxygen species. And we were able to cut that by about half with our super duper antioxidant. And if we moved them together, this one didn't work so well. The reactive oxygen wasn't so high in that one. We usually stress the cells to try to, I'll skip over that, to try to make them increase the reactive oxygen. In that case, we didn't quite get the pre-treatment very well. So we're looking in those sets of medications for drugs that will improve the secondary effects of having propionic or methylmalonic acidemia. How about what else can, and in the therapeutic RNAs, we're looking for something that makes new protein but is temporary. Well, what can we do to make new protein but do it on a permanent basis? And that's gene therapy. Now, gene therapy's been around the corner for 25 years, and 5 years ago I was very skeptical that we would be even close to it, but we're there. There are several groups that are interested in gene therapy, and you're going to hear a couple of talks, and Dr. Vivitti had some really interesting options for this. I am not a gene therapy experimenter, so in looking for options for gene therapy, I've been talking to biotech companies who are interested in developing it for MMA. When you talk about gene therapy, there are all kinds of different viruses that are natural viruses but can be modified so that they no longer cause disease but carry a gene of interest that can go into the cell, make that mRNA, make that protein, and get things improved. Now, the current way of doing gene therapy is to give you a new liver, right? If I give you a new liver, you've got a complete gene therapy. You've got a new gene, your propionic acid, propionyl-CoA carboxylase, your methylmalonyl-CoA mutase are now 100% normal. And the problem with that is that it's kind of a scary procedure, right? I mean, we're going to take you to the operating room, we're going to take out your liver, and we're going to put a new one in. That used to scare me like the dickens when I got to Pittsburgh, because back then, let's see, everybody's still here for Mayo, I gotta be careful. Back then, when I was at Mayo, they didn't have a very good pediatric liver program, liver transplant program. So I was used to thinking of this as high risk. I got to Pittsburgh, and suddenly it was a different story. What I can tell you is that in 30 years in Pittsburgh, nobody who has been transplanted for a metabolic liver disease has ever died getting the procedure done. So 100% survival rate. When you start getting numbers like that, it's pretty easy to think about what else can you do with that. Well, what happens now, you know, in the subsequent years? Well, so here in the 1980s, there were some technical problems.